chronic kidney disease, acute renal failure, dialysis, and HUS, which will be the end of this multi-series on GU in pediatrics. Chronic kidney disease, or CKD, refers to gradual and irreversible loss of kidney function over a period of months to years. While the condition cannot be cured, it can often be managed conservatively through a combination of medications, diet modifications, and close monitoring. Progression to end-stage renal disease. As CKD advances, it progresses to ESRD, the point at which the kidneys can no longer sustain life without dialysis or transplant. It's typically diagnosed when your GFR, glomerular filtration rate, falls to around 10% of normal function. Etiology and incidence in younger children. In younger children, CKD often results from congenital or structural abnormalities like obstruction in the urinary tract, VUR, renal dysplasia. These conditions can cause chronic scarring and progressively decline in kidney function. Etiology in our older kids could be a result from acquired disease such as glomerulonephritis, pyelonephritis, hemolytic uremic syndrome, HUS, which we'll talk about in the last slides. Unlike adults, secondary causes such as diabetes and hypertension are rare in the pediatric populations. Incidence, the incidence of CKD progressing to ASRD in children under 19 years of age is approximately 18 in 1 million. Studies also show the highest incidences is in white adolescent males. Key takeaways, although it is irreversible, early recognition and intervention can slow progression, preserve renal function, and improve long-term outcomes. Nurses are essential in education, medication adherence, dietary support, and psychosocial care for both the child and the family. Children with CKD may present with a wide range of symptoms because kidneys affect fluid balance, electrolytes, bone metabolism, blood production, and waste removal. Many of these sites develop gradually as kidney function declines. So when we're talking about electrolyte disturbances that are common, particularly we're going to see high potassium levels and low sodium levels. Children may experience fluid volume shifts, leading to either dehydration or fluid overload, depending on the stage of the disease and the treatment balance. Because the kidneys help regulate acid-base balance, reduced function leads to metabolic acidosis, contributing to fatigue, malaise, and muscle weakness. Renal osteodystrophy occurs when the kidneys cannot maintain normal calcium and phosphate balance, resulting in bone demineralization and rickets. Additionally, poor growth and delayed puberty are common due to both metabolic imbalances and nutritional deficiencies. Hematological effects. Anemia can result from decreased production of erythropoietin, the hormone that stimulates the blood. Children may appear pale, tired, and easily fatigued. Cardiovascular and blood pressure. Hypertension also develops from fluid retention and increased vascular resistance. Blood pressure control is crucial to slow kidney damage progression. Children may experience decreased appetites, poor feedings, nausea, and vomiting due to the accumulation of the uremic toxins in the blood. As waste products build up, children can develop headaches, irritability, confusion, difficulty concentrating, all signs of uremic encephalopathy in severe cases. In short, CKD affects nearly every system in the body. Recognizing these manifestations early allows for timely interventions to improve quality of life and slow disease process. CKD in children can be difficult to detect early because the symptoms, as we just noted, can be really non-specific. Diagnosis relies on clinical assessment, lab values, and imaging to identify declining kidney function over time. On physical examination, we may notice a short stature or failure to thrive, both of which reflect chronic illnesses and poor nutritional status reduced to kidney function. Growth delay is one of the earliest clinical cues in pediatric CKD. Laboratory findings, we're going to see rising serum creatinine and BUN levels that are key indicators that kidney filtration is declining. As it progresses, these values continue to rise and are often monitored with disease severity. We can do a creatinine clearance test, which is estimation of the glomerular filtration rate, which we know is a direct measure of kidney function. As kidneys deteriorate, creatinine clearance decreases, signaling reduced ability to filter waste. Imaging studies, we can do bone radiographs are performed to see if renal osteodystrophy has occurred, which would be a bone disease caused by imbalances of calcium and phosphate metabolism related to kidney dysfunction. Diagnosis of end-stage renal disease, ESRD, is made by monitoring your serum creatinine, your GFR levels, and quality of life indicators, such as growth, energy, and nutrition. When kidney function declines to 5 to 10% of normal, conservative measures are no longer effective. At this stage, the child requires dialysis or kidney transplant to sustain life and maintain metabolic stability. So, chronic kidney disease diagnosis relies on recognizing those subtle signs of growth failure, tracking renal function trends, and intervening before end-stage renal disease develops. Early detection and consistent monitoring can significantly improve long-term outcomes. Managing CKD in children is complex and requires multidisciplinary team, including physicians, nurses, dietitians, social work, and nephrology specialists. The goal is to slow the disease progression, manage the symptoms, and maintain quality of life until maybe transplant becomes necessary. So dietary management is one of the most critical components. The focus is on regulating fluids, electrolytes, minerals, and waste products to reduce the kidney's workload. Sodium and fluid intake are restricted to prevent edema and hypertension. Phosphorus restriction helps manage renal bone density. Potassium restriction prevents hyperkalemia, which can cause our dangerous cardiac effects. Protein intake is controlled. It's not eliminated, and that'll help to reduce nitrogenous waste, which will build up medications. There's lots of medications that we use. So we can use diuretics to help manage fluid overload and hypertension. We can use antihypertensives. We can use sodium bicarbonate to help with our metabolic acidosis. We can use the synthetic active vitamin D to help support bone metabolism and calcium regulation. And we can do phosphorus binders to reduce phosphatase absorption from foods and help prevent bone disease. We can do dialysis when conservative therapy can no longer maintain metabolic balance or growth. Dialysis is initiated. It could be intermittent, it could be continuous. It really depends on the overall child's age, size, and disease. Dialysis will help to remove excess fluids and waste while we're awaiting a kidney transplant. So effective management relies on coordinated multidisciplinary care, strict dietary adherence, consistent medication management, nurses' role, educate, monitor, and support families for navigating a very long-term treatment. Just a little bit about dialysis, right? So, for an acute kidney injury. The number one cause of acute kidney injury or acute renal failure in children is dehydration. And when the kidney function declines, whether acutely or chronically, we can use dialysis to kind of balance and remove waste products, regulate our electrolytes, and control fluids. So the purpose of dialysis is an artificial replacement for that lost kidney function. It's going to remove excess fluids and those wastes and maintain our electrolyte mineral balance. It can be used temporarily in acute renal failure to give those kidneys a break and a chance to kick back on, or it can be used during our end stage kidney disease because the kidneys have failed and we need this until we can get a new kidney. We can have hemodialysis, which is where we have the child's blood that's pumped through an artificial kidney, the dialyzer, waste products and extra fluid are removed, and then the blood is returned to the body. We need either a central access to this or the development of a atrial venous shunt or a fistula. Usually, we do it 3 to 4 hours a day, and it can be 3 days a week. There's also peritoneal dialysis where we have a catheter into our peritoneal cavity, and the peritoneal membrane acts as a natural filter. So then we instill the dialysis into the peritoneal cavity through the catheter. The membrane of the peritoneum naturally filters it, and then the waste products and extra fluid are removed through the dialysis fluid. In summary, dialysis is a life-saving intervention for children with kidney failure. The choice between hemodialysis and peritoneal dialysis really depend on the child's age, stability, lifestyle, and family resources. Our role is monitoring access sites, education, and supporting adherence of treatment. Transplant considerations. So, for children with end stage renal kidney transplant is an ultimate therapeutic goal. It provides the best opportunity for a normal lifestyle, growth, and development compared to long term dialysis. However, it's important to emphasize that transplant is not a cure, it's a treatment, and it's going to require lifelong continued management. Post-transplant care lifestyle, children must take daily immunosuppressive medications. They're still going to require frequent blood tests. They have regular office appointments, and follow-up care is critical for maintaining that transplanted organ's function and preventing complication. Donor sources. Kidneys can come from living donors or sometimes deceased donors. Living donors are often family members, such as parents, siblings, or grandparents. Sometimes we have non relatives that donate. The donor must be in overall good health and have normal kidney function. Rejection, the most common complication from transplant is rejection of that new kidney. We do the immunosuppressive therapy to prevent this, but it can still happen. Some common immunosuppressive medications, we can give Prograf, Cellcept, some prednisone. Those drugs all suppress the immune system actively to prevent the body from attacking the transplant organ. Infection risk and monitoring. Because those medications suppress the immune system, infection risk is pretty significant. Children need to be monitored closely if they start to develop fever or subtle signs of infection, if they have changes in urine output, if they're starting to be fatigue or malaise. So the key summary here, children with transplant, this allows the child with end-stage renal disease to return to school, play, and have a more normal life, but it really requires strict adherence to medication, lifelong medical follow-up, and as a nurse, our critical role is teaching the families, monitoring for early signs of rejection or infection, and supporting medication compliance. HUS. This is a serious condition that primarily affects the kidneys and the circulatory system. It's one of the most common causes of an acute kidney injury in children. Most cases follow a gastrointestinal illness, typically when we have bloody diarrhea, suggesting an infectious origin. So your etiology. Most often infection is with Shigella producing E. coli. Children usually contract this through improperly cooked meat, unpasteurized milk, or contaminated food or water. Although it is rare, outbreaks can occur in daycare centers or from contaminated public food sources. The pathophysiology, we have two key characteristics of the E. coli strain. We have one, attachment and growth. The bacteria attach to the intestinal mucosa, allowing them to multiply and produce toxins. Once the toxins are produced, then the bacteria release the Shigella toxin that damages the endothelial lining of small blood vessels, especially in the kidney. This triggers a severe inflammatory response, leading to capillary occlusion, decreased renal blood flow, which results in your acute kidney injury. The systemic effects of this, the vascular injury in HUS doesn't just affect the kidneys, it can also impact organs throughout the body. We can get anemia that occurs when the red blood cells are damaged and fragmented as they pass through the narrow vessels. This leads to a microangiopathic hemolysis. This leads to hemoglobinuria, where the hemoglobin appears in the urine. We can get thrombocytopenia because platelets become trapped and destroyed within damaged vessels, reducing platelet count and impairing blood flow. These combined effects, the hemolytic anemia, the thrombocytopenia, and the acute kidney injury, form this classic triad of HUS. So, in summary, HUS is a toxin mediated vascular disorder triggered by certain strains of E. coli. It results in red cell destruction, platelet loss, and renal injury that can lead to acute renal failure, life threatening complications if not recognized and treated. Early identification and supportive care are crucial to recovery. So, what are our manifestations? The clinical manifestations of HUS reflect renal impairment, electrolyte disturbances, and systemic effects from hemolysis and vascular injury. Because the disease primarily affects the kidneys, most symptoms are linked to loss of filtration or accumulation of waste products. With our laboratories, electrolyte abnormalities, as the kidney function declines, sodium, potassium, and phosphate levels become imbalanced, which can affect your heart rhythm and your heart muscle function. Fluid volume shifts. Depending on the stage, children may experience dehydration or fluid overload, both of which can worsen renal perfusion and blood pressure. Increased BUN and creatinine, the rising of these levels indicate reduced filtration and acute kidney injury. Acid-base imbalances, loss of kidney's ability to excrete acids leads to metabolic acidosis, which contributes to fatigue, confusion, and muscle wasting. Non-specific non-specific systemic symptoms. Because HUS affects multiple organ systems, children often present with vague or nonspecific symptoms, such as poor feeding and decreased appetite, early indicators of illness and metabolic stress, vomiting due to uremia or the toxin buildup, seizures from electrolyte imbalance, or accumulation of waste products affecting the nervous system. And these neurologic symptoms signal severe involvement and require immediate medical attention. So, in summary, children with HUS may present with really subtle early symptoms that progress to acute renal failure, neurologic changes, and metabolic instabilities. Prompt recognition of these warning signs allows for early intervention and improved patient outcomes. What's our therapeutic management? So the diagnostic process begins with a very careful history and understanding of what the clinical presentation is. It's essential to ask about any recent GI illnesses, particularly the bloody diarrhea, since most cases follow that infection of the Shigella toxin producing E. coli. This is history often provides the strongest clue for the underlying cause of this acute kidney injury. Additional laboratory studies may include CBC, platelet count, renal function, stool cultures, and we'll get a presence of E. coli or Shigella producing toxins. Therapeutic management treatment is primarily supportive, focused on stabilizing the renal function, restoring fluid and electrolyte balance, and preventing complications. So, with our fluid management, we want to replace those lost fluids. We want to carefully restore perfusion without overloading the kidneys. Children are often dehydrated at presentation due to the preceding diarrhea, yet, aggressive fluid replacement should be avoided to prevent worsening injuries. We want to eliminate the causative bacteria. So, supportive therapy includes stopping exposure to the infectious agent. In some cases, antibiotics are um, avoided as killing bacteria too quickly can cause increased toxin release, worsening the condition. Increased thrombocyto and erythrocyte levels. Because of that hemolytic anemia and thrombocytopenia, children may require some blood transfusions. Overall, the goal, we want to make sure that the management centers around early recognition, careful fluid regulation, supportive blood replacement, and renal monitoring. Prompt intervention can mean the difference between full recovery and a long term renal impairment. That is the end of GU.